Guys, let's talk about an interesting thing you've probably never even considered, and it's why CMS keeps rolling out new payment models instead of just trying to make the perfect version of Medicare. So like ACOs, the KCCs, the ambulatory models, these things don't happen overnight, right? CMS plans these things, they put them into law, and then they pilot these programs to see if they will help benefit Medicare. Let's talk about why they're doing that instead of just making demands that would seem to transition Medicare immediately, and why that's not reality. This is Ansolve, probably a 5 or 6 Medicare minute. Let's get it. Okay, so to dive into this thought then, we have to understand CMS has tried to fix traditional Medicare, and some of the ways the system is gamed or some of the ways that Medicare is hemorrhaging money, right? So they've done across-the-board payment cuts. In fact, up until this year, the American Medical Association was ticked off because physicians' cuts had been 5 years in a row they had been cut. They've tried bundle payment experiments, and they've tried readmission penalties for the same people going to the hospital for the same diagnosis. So to give an example on these readmission penalties, they came out with what's called the HRRP, that's the Hospital Readmission Reduction Program, where CMS would penalize a hospital for avoidable readmissions. And essentially what happens is in the short term, readmissions dropped, or at least initially they did. However, hospitals adapted their behavior, and because of that, overall Medicare spending still climbed. They found ways to bring people without admitting them and keeping them outpatient. So what CMS learned is that just from tweaking that payment isn't enough to overall change the system, right? Because the hospital would find a way to make money. And then CMS's earliest big test was with something called the CJR, the Comprehensive Care for Joint Replacement. So knee replacement, hip replacement. Instead of paying separately for the joint replacement surgery, then the hospital stay, then rehab and a follow-up, CMS would pay one large bundled amount for the entire episode. Here's the problem with that. Not everyone's the same. Sometimes you have people who have joint replacement, they stay a few days in the hospital and they go home and they're good. Other times people have to go into rehab or skilled nursing care, right? And that could last for weeks. And then other times you have long chronic issues where you need more treatment. So the takeaway on this one is that bundled may work for specific people in a specific episode, not the whole system then. And then CMS came out with the KCC, the Kidney Care Model, which is the Kidney Care Choice Model, which they should have done really well in because they've had experience with ESRD patients for decades. And they know ESRD is an expensive diagnosis with predictable utilization, high claims, and high hospitalization rates. So CMS came in and they tested their capitated payments, their shared risk with MA plans and hospitals, and incentives for home dialysis and transplant members. And this was another example of CMS trying to test a risk transfer on a population that they do understand pretty well. And now we have, fast forward to the ACO and the REACH plans and these things transitioning into access. So this is once again CMS going after a pilot program. Oh, somebody's calling me. Where was I? They're going after a pilot program on shared risk. And in these models, I talked about this the other day, doctors will still bill Medicare, but the organizations above them will be responsible essentially for the whole cost. And quality scores now will likely affect what kind of dollar they make. And the downside is costs could blow up. So CMS is testing with the reach and access, the accountability and cost predictability, and provider willingness to accept that risk or not. And if that doesn't work, guess what? They'll shut it down and they'll redesign it. Because remember, this ultimately is a pilot program. Another example, there's one for dementia patients, the guide model is what it's called. So CMS recognizes that dementia is driving a massive Medicare and caregiver cost. And fee-for-service has historically ignored the burden on the caregiver who's having to spend their time taking care of the dementia patient. So this guide model is going to test monthly payments, care coordination, support services, reduced ER and inpatient use, and it's going to pay the caregivers yearly. This isn't like some random thing. It's CMS testing whether a non-traditional model will support or at least reduce long-term spend on their end. Okay, so what does CMS know with these pilot programs? They understand that it's not one size fits all in Medicare. Someone who may respond to a treatment in one way might not respond the other way. Prescriptions are different, inpatient, rehab, outpatient, all this is different. Urban areas are going to have different responses than the more rural areas. ESRD patients aren't going to respond like a dementia patient. Dual eligibles might not respond like a traditional Medicare or a C-SNP patient. So they run all these multiple pilot programs at the same time to see what works, for whom it works, what's it costing, what scale can they blow this up to. CMS can't just say, hey, new Medicare payment system starts tomorrow, you're opted in whether you want to or not, right? Because we're talking about trillions of dollars in spending over just a few year period, much less a decade or two. We're talking about triggering lawsuits against Medicare, disrupting the cash flow to the providers who are in Medicare, and ultimately impacting access to care of the members. So these pilot programs are how CMS tries to save Medicare without breaking it. They're just being cautious, so they're introducing these new ideas. They're essentially experimenting to stress test Medicare's future, not for fun, but because we have to do something so that Medicare doesn't go insolvent. And whether you love or hate these things, one thing's very clear: fee-for-service Medicare is not the system that CMS is planning around anymore. They're experimenting to see, hey, how can we keep Medicare solvent for longer? And what can we do to reduce the overall stress that's in the federal budget?